This is another topic in experience in medicine. It seems as if the coronavirus issue has not left us in the country and it remains an issue. And often enough, we get lots of questions about what's going on. One of the important parts which we've gotten about is about the distribution of the COVID vaccine and the different inequities in the healthcare system in distribution of vaccine and patients who get sick, who may be more of minority or lower social income who get sick. I may not really wade too much into inequities because it's a more detailed topic that takes a long time to be able to explain and provide a solution that works. However, I'm going to talk about a solution that, at least in New York State, should work and should have been implemented. One of the things in which the state of New York has been criticized is the classification of people who are priority for the vaccine. I think for many people, they had felt that an age may have been an easier way to go about it. That means decreasing the age from 85 to 75 to 65 to 55, and then maybe to 45, and then subsequently to everybody else. However, more importantly, I think is the fact that there are not enough vaccines. And not only that, the vaccines are being restricted to what New York or maybe New York City have always favored hospitals. The reality is that in the United States, most care are delivered by primary care doctors or regular doctors who are community doctors. And I think that this is one of the biggest failures of the distribution of the vaccines. Vaccines should have been made available to people who practice in the community and are able to verify even the ability for certain patients to be able to be eligible for the vaccine. So, for example, a vaccine is being supplied now to a hospital. The hospitals don't know the patient, but you are creating an eligibility criteria that says that they may have an underlying illness like bronchiectasis or COPD. However, the vaccine is not being supplied to the person's primary care physician or specialist who already knows that the person has that and can verify. Now the person has to get a letter from that doctor to go to a hospital or go to a pharmacy to get the vaccine when the vaccine could have as well been supplied to the primary care physician's office or to the specialist office who are willing to be able to give the vaccine. So this particular solution will also solve the inequities that occurs in medicine, because essentially in communities, whether they are Hispanic, they are Black, they're Chinese, they are South Indian, they are South Asian, they already have doctors that practice in the community and therefore will be automatically able to access the patients that need these vaccines, and they'll be able to judge their eligibility easier. This single aspect in change of supply of this vaccine will change the way people get the vaccine. People will get the vaccines faster, and it will distribute it more equitably across the nation. So maybe bypassing the state system entirely, in which the federal government can ascertain either through the DEA system or which is federally controlled, be able to access people who have functioning practice in communities and supply vaccines directly to them. And that way, the vaccine rollout will be faster. So this is a solution that is begging for a fulfillment. And I think this will be one way in which the vaccine can be delivered, and by the end of June or the end of July, every American who needs a vaccine should be able to get one.